Good afternoon, everyone. Welcome to our pediatric and adolescent session. It is my great pleasure to present our first speaker today, Professor Abdelaziz Elamin. He's a professor of pediatric and child health at College of Medicine and Medical Science at Arabian Gulf University of Bahrain. And today he will be presenting to us growth hormone in pediatrics and adolescents. تفضل دكتور.
Assalamu alaikum rahmatullah ta'ala barakatuh. Hello everyone. My talk today will be about growth hormone treatment in children and adolescents. And during my talk, I will going to go through the following points. Like I will start with a historical note, then I will talk about the biosynthetic growth hormones and the physiological aspects and their function. Then I will talk about the growth hormone treatment and the challenges we face with that kind of treatment in our clinical practice. And then I will come to the point about the long-acting growth hormones and just with a little comparison about daily versus weekly growth hormone injections. And I will conclude my talk after that. We know that the first time scientists start talking and trying to isolate this growth hormone actually started in 1945 when Lee and Evans at the University of California, they purified the growth hormone from bovine pituitaries, and Westermeyer and Tufts University in Boston purified it from porcine pituitaries. And then they tried these purified preparations on some human volunteers. Unfortunately, none of these preparations showed significant biochemical or metabolic activity in the human volunteers because the effect of growth hormone are species specific. The breakthrough occurred in 1956 when Morris Rabin at Boston City Hospital managed to purify growth hormone from the human cadaveric pituitaries. This is a picture of Dr. Morris Samuel Rabin, who is a physician researcher, graduated from Boston University and practiced in Boston City Hospital. His initial ventures were in the physiology and clinical aspects of thyroid gland. And he started, most of his work was in thyroid gland. Actually, by the end of 1950, he had published 3 papers, 2 articles on the effect of antithyroid agents, and a 3rd paper on the use of radioactive iodine in humans. He was the first one to isolate natural growth hormone from human cadaveric pituitaries. This was done in 1956. And he injected the first patient with the pituitary-derived growth hormone in January 1957. And that case was reported in the Journal of Clinical Endocrinology and Metabolism in 1958. In 1984, the pituitary-derived human growth hormone was abandoned because 4 patients from those who received the treatment with this cadaveric pituitary-derived growth hormone developed a Creutzfeldt-Jakob disease, which is a fatal neurodegenerative disorder. And this is why it was abandoned, and the use of this kind of pituitary-derived growth hormone was stopped. Then we went into the area of when this synthetic recombinant human growth hormone developed, and it was licensed for the use in growth hormone deficient children in 1985. At that time, it was only licensed for children. This was in 1985. In 1996, the Food and Drug Administration in the United States approved this type of growth hormone to be used also in adults. This was in 1996. As you know, it was the second recombinant hormone introduced to the clinical practice or to the market after the insulin. These biosynthetic growth hormones preparation are highly purified and almost free of contaminants. And the possibility of viral transmission through this kind of preparations or these injections has been virtually eliminated. And also it has a very low antigenicity. So the antigenicity of this preparation is low and the possibility of developing antibodies that would neutralize these effects is minimal. Actually, most of the studies, in many series, we found that there is some growth hormone antibodies can be detected in up to 10% of the treated children after 5 or 6 years of therapy, but with very rare exceptions, which is less than 0.1%, these antibodies do not impede the effect of the growth hormone. Growth hormone is a 191 amino acid polypeptide, sensitized, stored, and secreted by the somatotropes of the anterior pituitary. And growth hormone gene locus is located on chromosome 17. It is secreted in pulses throughout life, and secretion increases during puberty and pubertal growth birth and decreases in adulthood. Growth hormone binding proteins minimize the fluctuation of the serum growth hormone that is associated with these pulsatile secretions. So this is the main function of the growth hormone binding proteins, to keep a level which is without much fluctuations. And growth hormone, it exerts its action through two mechanisms. Either it works directly by binding to its receptors on certain tissues like bones, muscles, and fat, and indirectly via insulin-like growth factor 1, which is sensitized in the liver. Growth hormone synthesis and release is mainly controlled by hypothalamic hormones, اللي هو two hormones, the growth hormone releasing hormone and the growth hormone inhibiting hormone, which is also known as somatostatin. But some other hormones also affect the function and the secretion of growth hormone from the anterior pituitary. Ghrelin and gonadotropins stimulate the growth hormone release, while hypothyroidism and excess corticosteroids inhibit the release of growth hormone. Other factors that stimulate the release of growth hormone include sleep, exercise, physical stress, and hypoglycemia. Acting on bone and muscles, growth hormone promotes linear growth through two mechanisms. It stimulates bone formation, increasing the bone mass, and enhancing the protein synthesis and increase the active muscle mass. It also has other metabolic effects, like it reduces the total and visceral body fat by increasing lipolysis and redistribution of fat. And it has an anti-insulin effect, inhibiting the uptake of glucose in peripheral tissues and stimulating the glucose synthesis in the liver. The benefits of growth hormone treatment in children, and even now it is also in adults, it is improved linear growth in children and adolescents, and increase the bone density and the lean body muscle mass, and reduce the total and visceral body fat. And in adults, studies suggest that it improves cardiovascular function and improves memory, alertness, and concentration. So we can say the main effect of growth hormone in children and adolescents, it is for growth, and this is why we need higher doses for treatment in this group of patients, while in adults, we mainly want it is metabolic effects, and we are using in general lower doses of growth hormone in adults. What are the effects of other hormones on the growth hormone therapy? Because we said that there are certain hormones that can affect the secretion and function of the other of the growth hormone in children and adolescents. Children treated with growth hormone may experience transient or persistent decline in serum thyroxine levels. Studies showed that in approximately 25% of patients, serum thyroxine became abnormally low, which impairs the response to growth hormone treatment. This is why thyroxine levels should be monitored periodically during growth hormone therapy to detect and prevent this treatable cause of a poor response to growth hormone treatment. Also, excess cortisol, whether pathological or iatrogenic, impairs the effect of growth hormone, and as little as 7.5 milligrams of hydrocortisone per day may suppress growth in school-age children. This is why what we recommend in a patient with hypoadrenalism, especially children and adolescents, the daily dose of cortisol replacement therapy should be reduced to the minimum that is needed to alleviate the symptoms to allow the growth hormone to work to enhance the growth of these patients. These are the current indications for growth hormone therapy in children and adults. You can see it is more than 10 indications. The most important is the growth hormone deficiency. And then in patients with chronic renal failure, certain syndromes like Turner syndrome, Prader-Willi syndrome. For children who are born as small for gestational age, it is also approved for idiopathic short stature, Noonan syndrome, and recently for cystic fibrosis patients and patients with achondroplasia. And still there are some other indications like hypophosphatemic rickets and CHOX gene deficiency. Before starting growth hormone treatment, pediatricians, pediatric endocrinologists, they will do a thorough physical examination, including a fundoscopy. They will calculate the growth velocity from the growth charts and the mid-parenteral height and the genetic target height. They will go into measure the insulin-like growth factor 1, thyroid hormones, cortisol, and hemoglobin A1C, request an X-ray for bone age, and other investigation according to the, if needed, according to the clinical condition of the patient. And then they may start this growth hormone treatment. Starting growth hormone treatment early increases the chances of reaching the adult target height range. We prefer or we encourage parents with short children to present early. So if you can start treatment by the age of 7 years, most likely you're going to get good results and the child may reach his potential final adult height. The first year of treatment usually produces the greatest growth increment, between 10 to 12 centimeters. And in the second year, this will start dropping gradually. And in the second year, the increment will be around 7 to 9 centimeters. Results are usually seen within 6 to 6 months after starting treatment. You will going to notice improvement in the growth velocity. Seasonal variations in growth rate during growth hormone therapy have been observed with peaks in summer and nadirs in winter. There is no explanation for this, but this is proven from studies and clinical observations. In patients and children and adolescents with growth hormone deficiencies, treatment should continue until growth is completed and final adult height is reached. Growth hormone is given at bedtime. The hypothesis behind this is that the nocturnal administration mimics the physiological growth hormone secretion, which may add to its efficacy. Early in its use, growth hormone was administered twice per week. This was later increased to 3 times per week. And when 5 injections per week were shown to yield better growth response and better increment in growth velocity, daily administration of growth hormone became the standard practice. Also, growth hormone, when we started the treatment, it was given intramuscularly. Later on, studies showed that if it is given subcutaneously, which is causing less pain for the children and the patient, it is as equally as effective as intramuscular injection. So the practice shifted to subcutaneous injection instead of intramuscular injection. The dose recommendation for growth hormone, it depends on the indication, of course. Generally, children with growth hormone deficiencies, they will need a dose in the range between 0.18 to 0.35 milligram per kilogram per week. And for the other indication, we need the higher doses. And usually in our practice, we use 0.5 milligram per kilogram per week for the other indications for growth hormone treatment in children and adolescents. In adolescents, because the time allowed for them before the bones will be closed and they will reach the final adult height is short, maybe a few years, we prefer to use a larger dose so we can induce a more rapid and more stronger effect for the growth hormone. So the dose we recommend for the adolescent is 0.7 milligram per kilo per week. And this is recommended by the American Association of Chronic Endocrinologists. But this is not endorsed by some other endocrine societies around the world. So there is no consensus about whether to use this dose in all adolescents or not to use it, just to use the normal dose for growth hormone use for growth hormone deficient children. The debate about the growth hormone dosing in puberty is still there are 2 points here. Actually, most of the large random research and trials showed that an increase in growth hormone dose, when you double the dose from 0.35 to 0.7, this may improve the height standard deviation scores significantly without any increasing the adverse effects of the treatment. This is documented in many studies, but there is another point saying that if you start giving these high doses, you may actually accelerate the development of the puberty and the pubertal maturation, and this eventually will going to lead to cessation of growth. So you're going to end by a shorter child or shorter adolescent at the end. So it is still, there are 2 points here, it is still a debatable question. How we monitor growth hormone during treatment? In the clinic visits, we check for patient's compliance with the treatment. Then this is the most important part in the treatment, that they should be compliant so they can get the expected results. We're going to verify the growth velocity using the growth charts, and we identify the possible side effects, if any. And then we're going to assess the dose according to the body weight, according to the IGF-1 levels, and also to the bone age. We have certain prediction modules which are there. We can use them to predict how we can modify the dose in these patients. We need to measure the thyroxine and cortisol every 6 months, particularly in the first 2 years of therapy, and as needed after that. Growth hormone, what is the effect of growth hormone on glucose metabolism? Also, growth hormone reduces insulin sensitivity as a part of its physiological effects. However, it is the overall effect on glucose homeostasis is minimal. No increase in incidence of diabetes, either type 1 or type 2 diabetes associated with growth hormone treatment. And diabetes mellitus is not a contraindication to growth hormone treatment in children and adolescents. And those who are already diabetic, we can give them growth hormone if they need growth hormone treatment. What about other acute illnesses? There is no data to support discontinuation of growth hormone treatment during acute illness. There is a risk of hypoglycemia, always should be considered in children with growth hormone deficiency who discontinued growth hormone treatment. We need to monitor glucose homeostasis, lipid profiles in patients with chronic renal failure who are doing dialysis or who are just prepared for renal transplantation according to the standard clinical practice guidelines. There are certain special situations when we need to have to do certain modifications for the treatment of growth hormone treatment. This is like in the children with idiopathic short stature and the adolescent who have little time before puberty, and the subsequent cessation of growth is a risk. A novel approach is to combine the growth hormone treatment with concomitant suppression of puberty using gonadotropins releasing hormone agonists and aromatase inhibitors. Several studies have shown that the combined growth hormone and gonadotropin releasing hormone agonist therapy in adolescents has resulted in attaining the expected height velocity without adverse effects on the patients. So this is an important thing we can do in these adolescent children and in some patients with idiopathic short stature, this combination therapy. What are the side effects of growth hormone treatment? There are so many side effects, so it is not very common, but I will going to mention all of them. The most common is the benign increase in intracranial pressure, or we call it benign intracranial hypertension. This is followed by the arthralgia and the myalgia. And the others are rarer side effects, like the peripheral edema, carpal tunnel syndrome, sleep capital femoral epiphysis, mild postprandial hyperglycemia, prepubertal gynecomastia, enlargement of the skin nevi, obstructive sleep apnea, and the development of antibodies against growth hormone. And there is a rare complication, which is acute pancreatitis, reported from one center in 1995. And in children with scoliosis, the degree of the scoliosis may get worse when the growth is accelerated. These are the side effects. Benign increase in intracranial hypertension actually is reported in 1 per 1,000 children. So it is rather a common side effects. Usually it appears in the first 8 weeks to 10 weeks of therapy. And the cause, it is mainly due to the increase in salt and water retention. Patient will complain of headache, impaired vision, vomiting, and it resolves rapidly when growth hormone is stopped. and then after 2 or 3 weeks, we can restart growth hormone with the lower dose, and the dose is slowly increased to the recommended dose. And the study showed that the benign increase in intracranial pressure or this intracranial hypertension will not going to recur in most of the patients. What about the risk of growth hormone therapy and the risk of malignancies? In 1988, a report from Japan describes the detection of leukemia in some growth hormone treated children. And that report raised a lot of concerns about the safety of such therapy. But a careful review of that research found that the patient who developed leukemia had predisposing factors, which is not related to the growth hormone treatment. And then furthermore, several systematic reviews and meta-analysis found no evidence of an increased risk of developing leukemia or any other type of neoplasm in growth hormone treated patients. There is no evidence that growth hormone treatment increases cancer risk. But however, in patients with previous malignancies or those with a history of radiation therapy, and in the patient groups that they have intrinsic or inherent tendency to develop malignancy, in pediatrics, we know that the neurofibromatosis type 1, Fanconi syndrome, patient with Down syndrome, patient with Bloom syndrome, they have an inherent tendency to develop malignancies. So in this group of patients, growth hormone treatment may increase the risk of recurrence or appearance of new cancers in this particular group of patients. This is why in those group of patients, we must be very careful and we should monitor them regarding tumor formation very carefully. We stop growth hormone when there is a poor response to treatment. Here we define the poor response to treatment if the increment in the height velocity is less than 50% after 1 year of adherence to therapy, if there is poor compliance despite education and motivation, and after reaching final adult height in non-growth hormone deficient patient. In growth hormone deficient patient, we are going to continue with growth hormone in the adulthood as well. Sometimes we stop growth hormone temporarily in 2 situations. After renal transplantation, we have to stop the growth hormone for 1 year. Then we can restart the treatment. And if the patient develops benign intracranial hypertension, we stop the growth hormone treatment for 2 weeks. And then we reintroduce the treatment with a lower dose, as I have said earlier. What are the challenges we face in growth hormone treatment? Usually we face 2 problems which is here when we start this growth hormone treatment. The first one is the variability in the response to treatment. And growth hormone deficiency is the most common treatable cause of short stature in children, and it is the best response we usually see with this type of condition. But however, there is variability in the response to treatment from one child to another, which is always challenging. And so many times, even us as doctors or parents, we will come to ask, why is this child responded better than the other child for growth hormone treatment? Several endogenous and exogenous factors may explain why there is variability in the response of growth hormone treatment. The most important one is lack of adherence to treatment, or the indication of growth hormone therapy, the age of starting growth hormone therapy, the birth weight in the children with a small for gestational age, the pubertal status, what dose of growth hormone we are using, if there is any concomitant medications like steroids or anything associated comorbidities, including undiagnosed hypothyroidism, and rarely the development of antibodies. The second challenge is the non-compliance with growth hormone treatment. Poor adherence to the daily injections is a major challenge that reduces the efficacy of therapy. Adherence is particularly poor in teenagers, which is why this may explain why most of them, they were not going to reach their genetic target height or the expected adult height. And in one publication, they found that as few as 30% of adolescent patients had demonstrated good adherence to growth hormone therapy. And it's only 30%, 70% were not adherent. And the main causes of poor adherence in that particular study were inconveniences of the daily injections, lack of perceived benefits, and fear of side effects. A systemic review actually done in 2020 included 6 studies on non-adherence to daily growth hormone treatment in children and adolescents. It's reported rates of non-adherence range between 10 and 70%, with a mean of 48%. Well, common factors were also been in the injection site because of the injection, dissatisfaction with the efficacy of treatment, lifestyle disturbances, and concerns about side effects. Poor gross velocity as a consequence of non-adherence to growth hormone treatment is documented in many studies. And while the good adherence usually leads to good impact on gross velocity, improve the insulin-like growth factor 1 values, and improve the final adult height. This is my last part of presentation. It's about the new era of growth hormone treatment, which is the long-acting growth hormone preparations. Long-acting growth hormone preparation, by decreasing the injection frequency, long-acting growth hormone increase adherence and improve clinical outcome. Several recent studies have documented that the increasing use of long-acting growth hormone preparations in children and adults, and we are now entering a new era of long-acting growth hormone preparations, which will predictably be the preferred form of therapy for years to come. This is a characteristic of a long-acting growth hormone. If we need to have a successful growth hormone, it should be given weekly. Its entire dose should be given in a small single injection. Efficacy should be equal or superior to the daily growth hormone therapy. A safety profile also should be similar to the safety profile of the daily growth hormone therapy. It should also maintain the insulin-like growth factor 1 in the physiological range, no injection reactions, and it doesn't induce neutralizing antibodies more than the daily growth hormone injections, and the cost should be equal or less than the daily growth hormone injections. Okay, because of the problem of adherence to the daily injection of growth hormone, that was the main stimulus why several companies started doing a lot of work, doing a lot of research to create the long-acting growth hormone. And most of the efforts were started in the year of 2000. These kind of agents, the preparations which have been developed, we can describe them into 5 categories: either the depot preparation, prodrugs, vigilated preparations, non-covalent albumin bindings preparations, and fusion protein formulations. Interestingly, Nutribin, which is a depot, was the first long-acting growth hormone to be approved by the Food and Drug Administration in the United States in 2003. But it was removed from the market in 2004 because of manufacturing problems. Newer product came into clinical practice in 2022. This is the 5 mechanisms by which we can make a growth hormone, long-acting growth hormone. Making it depot preparation, this will delay growth hormone absorption from subcutaneous tissues. Prodrugs that will later be converted into body in the active growth hormone. This will prolong the half-life of the growth hormone. If you use the non-covalent binding, this will slow the release of growth hormone. Fusion proteins, which are synthetic polypeptides or immunoglobulin chains that slow the growth hormone release. While pegylation, as you know, is polyethylene glycol attached to the growth hormone. This will slow the release and degradation of the growth hormone. The available products, long-acting growth hormone products available now in the markets, we have, I gave example from each of the 5 groups. Fusion proteins, we have somatotropin produced by Pfizer. This is approved by the FDA, and this is used in more than 40 countries now around the world. The non-covalent albumin binding and somapactican, and this is produced by Novo Nordisk, approved also by the FDA, and for children and adults, and used in the United States, in other countries, in Saudi Arabia. Both these 2 are available. We have the depot, like other things which is approved in Europe, available in South Korea. We have a prodrug, one of them, which is available in China and several other countries, and the related one is available also and used in China. So we have around 5 preparations. The most commonly used are the first 2 preparations. And here, somatopactian and somatotropin are the most widely used long-acting growth hormone worldwide. They are registered and used in the Kingdom of Saudi Arabia since 2023. While international data on the advantage of weekly growth hormone showed better adherence, good growth velocity, physiological levels of IGF-1, safety, very good safety profile, which is like the daily growth hormone, and improved quality of life. And this map shows the countries which started where this long-acting growth hormone is used, like in Canada, in the United States in 2023, in the Saudi Arabia in 2023, in Europe also the licensed in 2023 in Japan also. In all these areas, it is licensed in 2023 and it is started being used since then. There is one study published by one of our colleagues from Saudi Arabia, Professor Abdel Al-Agha. He is a pediatric endocrinologist at King Abdelaziz University. He recently published a report about the findings of a 72 weeks prospective study on using long-acting growth hormone on 184 children and adolescents. The conclusion of that Saudi study in the clinical efficacy, this patient demonstrated significant improvement in height velocity and insulin-like growth factor 1, like the results seen with non-interrupted daily growth hormone. Safety profile was similar. The whole incidence of, sorry. Okay. What is happening? You stop me? ولا ده بقى حصل؟
Thank you, Professor Abdelaziz, for this rich presentation.
Okay.
We'll save the questions to the panel discussion.